Welcome to the blood count. I don't think there's any other laboratory tests that you're going to use as much, nor any that is probably as more important to your practice. So just to review some of the basics, obviously there's a lot more to know, but this should get you started. So on YouTube, I'm also going to post a few other videos that I found that relate to this topic. I'll try to update those as time goes on as well, but I do think that they'll supplement and maybe even sort of expand what's covered here. As I say, this is the basics and we'll go from there. So when you're looking at the blood count, the first thing that the majority of people look at is the hemoglobin. And the hemoglobin basically is your oxygen carrying capability, and it can really point you in a number of different directions for problems that people have. The majority of people that I know don't actually even look at the red count. It doesn't seem to really add a whole lot to what you're looking at, and as long as your hemoglobin is okay, having a slight decrease in your red count usually doesn't have a substantial impact on your function. The normals for anemia, or at least the normal of the hemoglobin, varies a little bit from lab to lab, but for most of us it's going to be 14 to 16 for men and kind of 13 to 15 for women. And so there does need to be even a little bit more of a decrease for most of us to clarify or classify something as anemia. So when I was a student, I learned the 11, 12, 13 rule. I think it's a useful rule. So if you've got a pregnant woman whose hemoglobin is lower than 11, she's anemic. A woman who's lower than 12, or a man lower than 13. That tends to mean that if you've got a man, even though the normal for the hemoglobin is 14 to 16, if you've got a man who's 13.7, 13.8, and he's stable there, the majority of people won't go digging. On the other hand, one should always kick in the differential diagnosis process before anybody makes any assumptions regarding what's going on. So let's give you a case. I think context is always a useful thing. You have a 57-year-old woman comes in and presents to your walk-in, and she complains of bright red blood per rectum. Now, she's got a history of hemorrhoids. The most probable thing that's going to be causing her bright red blood per rectum is those hemorrhoids. But whenever you do a differential diagnosis, you have to go through both a most probable scenario as well as a most serious scenario. And you do not want to miss a GI bleed, so you look at her vital signs. You see her pulse is 88. You see her blood pressure is 116 over 68. Obviously, those don't look too bad. Some folks would stop there and assume that this lady has some hemorrhoids, treat her for hemorrhoids, and go on from there. However, when you do the rectal, your finger comes out covered with blood, and you go back and you look and you see that her usual pulse has been in the 70s. And note she was in the 80s now, high 80s, and her blood pressure had been running, 138 systolically. So her blood pressure in the teens is a substantial decrease from this. In addition, you go ahead and you do some postural vital signs, and you see that laying down she's 128 over 82, so kind of similar to what she had been, but maybe even a little bit better. But when you sit her up and wait 2 minutes, she's 116 over 84, pulse goes to 88. And then when you stand her up, her blood pressure goes down to 98 over 60 and her pulse goes to 104. Now, there's not any real clear criteria for when postural signs are positive. For most people, if the systolic drops 20 or if the pulse goes up 20, they consider those to be abnormal postural vital signs, and the probability of either dehydration or hypovolemia related to bleeding goes up. So in this case, we're kind of worried about this lady. We do a hemoglobin, and her hemoglobin is 12.1 and 34. So again, that's somewhat reassuring. The problem is that you don't know how much she's bleeding. So in general, With this particular lady, if you had checked her hemoglobin 6 hours later, she would have dropped 2 full points of her hemoglobin, and her crit would have gone to 27. So we worry because we know that 3 points on the crit is the equivalent to a unit of blood. So whenever you have someone that you are suspicious that they're bleeding, in general, that patient will need to be hospitalized and will need to do serial hematocrits on them to make sure that they are not substantially bleeding. So this is one of those don't miss things that you really do not want to assume that someone's got hemorrhoids and then just treat them for hemorrhoids. You do want to make sure that this patient is not having a substantial amount of bleeding. So the other thing to remember is that when you're looking at the hematocrit, you can actually change the concentration by increasing the amount of fluid in the body. So whenever you have someone who is elderly, if they are dehydrated at all, the hematocrit may appear to be higher than it actually is, and then when you put them in the hospital and you rehydrate them, their crit will drop even though they're not bleeding. So in interpretation of the hematocrit, you need to keep that in mind. So the hematocrit in the elderly, again, on average, you're going to see a somewhat lower hematocrit in the elderly. This is a statistical norm. I think that this case really does point out where you don't want to just assume that the lower hematocrit is a statistical norm. You do want to go through your differential diagnosis process, make sure that someone is not bleeding or is not substantially dehydrated. So whenever you have someone who is bleeding, there's a lot of different tests that one can do to determine what is happening. One other blood test that you sometimes will do is the reticulocyte count. Now, the reticulocyte count is a count of the immature red blood cells. If someone has some sort of low-grade chronic bleeding, in general, the reticulocytes will go up. The other possibility, however, if someone is anemic, is that they are anemic because they have some kind of suppression of the production of the red cells in the bone marrow. And in that case, the reticulocytes will go down. So just to keep in mind that the reticulocytes can be measured and that it can be a useful test. You'll see the hematologists do this on a regular basis. Some primary care folks will do it. Others, will not use this lab very often. Now, whenever you have anemia, the first thing that the majority of people look at are the indices. And so the first indice that you're going to look at is the MCV, the mean corpuscular volume. So how big are the cells? What's the volume of the red cells? The MCH and the MCHC are secondary tests. They can be indicative of hemoglobin problems or other issues. Again, the majority of us in primary care are just going to look at the MCV. Are the cells big or are the cells small? So if the cells are big, we're going to be thinking more of folate or B12 deficiency. And then if the cells are small, we're going to be thinking about an iron deficiency. Now, iron deficiency is, most worrisomely related to bleeding, so always keep that in mind. Another possibility, once you've kind of ruled out bleeding, iron issues, is the patient may have thalassemia, and we'll talk about that a little bit more down the road here. The RDW is a sign of how much variability there is in the red cells. So if you have someone who is both folate deficient as well as iron deficient, they'll have, quote unquote, small cells related to the iron deficiency. They'll have some big cells related to the folate or B12 deficiency. And then on average, they'll have normal sized cells. And so the RDW gives you an idea of how much variability there is of the cells. We used to call this anisocytosis, where you'd have some very small cells, some very big cells, and some cells probably that were normal as well. So the RDW, as I say, is a great test to decide how much variability there is in the red cells. So since we're predominantly talking about the elderly in this course, let's talk about what anemias you would expect. The most common anemia that you're going to see in the elderly is an anemia of chronic disease. So you're going to have a normocytic, normochromic anemia. The patient will have some diabetes. They may have some renal disease. The diabetes may or may not be well controlled. The labs are usually minimally decreased and are relatively stable. So if you look back over time, you can see that they've had these anemias. You can, of course, also see iron deficiency anemia. Again, iron deficiency anemia in my mind is always bleeding until that bleeding has been ruled out. I never attribute iron deficiency to a dietary issue until I've ruled out bleeding. And then if the anemia is macrocytic, again, we go through the folates, B12s. There are some other things that can cause enlarged size of cells. Alcohol intake will actually do that independent of B12 or folate based on one of the metabolites of alcohol that occurs. So if you have somebody that has a macrocytosis, you've done a B12 and a folate, be aware that they possibly may be taking in more alcohol than what you think they are. Reticulocytes, because they still have the nucleus, are always bigger than regular red cells. So a person that has a lot of reticulocytes will also sometimes have a macrocytosis. So again, macrocytosis, B12 folate, in general, you're going to go ahead and draw those levels. If B12 is on the low side, you may actually do a methylmalonic acid just to make sure that they do not have a macrocytosis related to the B12 deficiency, even though the B12 is in the lower range of normal. In general, these are easy tests to do and interpret. Microcytic anemia, first rule out, of course, is bleeding. Most common cause of bleeding in this age group is going to be some sort of colon process. So generally, the first rule out is going to be colon cancer. Other cancers can do this as well, although it's hard to lose enough blood through the urine or through other causes to really end up having a microcytic anemia related to that. So, colon, you can have occult bleeding and have a fairly substantial amount of it without really being aware of it, but other causes are going to be less common. So in other words, the person that has iron deficiency anemia, in general, you need to make sure that you don't need to do a colonoscopy or an EGD. If it's acute onset, they're going to, obviously need evaluation for occult blood in the stool. You're going to have to get history in regards to the quality of the stools. And in general, you're just going to have to try to figure out, what's going on. To determine whether or not the person is actually iron deficient, the serum iron itself is really not a great test to do this. Some folks will do that, but the ferritin is a much better test to do this. Ferritin will go down much more predictably and much in a more describable way, if you will, in someone with iron deficiency anemia. The total iron binding capacity also should go up in anybody who is iron deficient anemic, and so when you have these kinds of issues, it'll be an issue. The ferritin, always remember that there is a population out there that has an excessively high ferritin, those people with hemochromatosis, so keep that in mind in regards to other issues. Another test that you'll sometimes see done, but not commonly, and it's not terribly helpful in regards to looking at anemias or similar, is the hemoglobin electrophoresis. So really, all you're looking at in the hemoglobin electrophoresis are for abnormal types of hemoglobin. So the hemoglobin S in sickle cell will be abnormal, and it will show up on hemoglobin electrophoresis. There is another test now called sickle cell trait, which is the more common screening test. Most African Americans will have had that done at some point in their life, and you definitely want to make sure that they don't have it. The college sports regulators have actually suggested that all college sports athletes be tested for sickle cell trait, regardless of race. So, there will often be kids come in that have this requirement if they're going to play Division I sports. So you will end up doing some sickle cell trait testing on those folks. There is a small group of folks from Quebec that actually have the sickle cell trait that are non-African American. So it can occur in Caucasians as well, but is obviously way more common in folks of African American descent. Hemoglobin C is an uncommon cause but can cause hemolytic anemia, and the fetal hemoglobin obviously is very common right after birth, and that's why babies get jaundice, is they're switching their hemoglobin F over to hemoglobin A and hemoglobin B. But hemoglobin F can also be present in thalassemia. So if you have someone that you suspect thalassemia, it is sometimes useful to go ahead and do a hemoglobin electrophoresis. It's important to note that hemoglobin electrophoresis is different than serum protein electrophoresis. So serum protein electrophoresis looks for types of albumin, types of globulin, those kinds of things. The nephrologists will often do that testing if someone has an abnormal kidney test, just to see if they have abnormalities of their immunoglobulins. But again, the other thing is that it will not test specific types of immunoglobulins. Even the SPEP won't. So if you want IgA, IgG, IgM, you have to order those separately. So we'll talk about that again in a later talk. So the white blood count. So the white blood count is where a lot of your bread and butter is for the blood count. When you're looking at the differential white blood count, there's several different types, but the basic white blood count should be in the normal range. If it's high, you definitely need to reflex and look at the differential. Most high white blood counts are going to be related to infection, most commonly bacterial infection. The other possibility that you always need to keep in mind is, has the patient been on steroids, because steroids will cause an elevated white blood count. So there are artifactual reasons that you can have to have a leukocytosis, which is what you say when they have a high white blood count. But on the other hand, you do want to look at the differential. Low white blood counts obviously can be a sign of viral infections. Very commonly, the white count will go down a bit in a viral infection. The other thing is that nutritional deficits can also cause a low white count. A little bit of a decrease in the white count we're not going to worry that much about, but a substantial decrease puts the patient at risk for the inability to fight off an infection. So there's, depending on how you define it, either 5 or 6 major types of cells on the differential. The polys, which are further divided into segs and bands, the lymphs, the monos, the eos, and the basos. So we'll talk about each one of those separately. The polys are also called neutrophils. When they were looking at the types of white cells, they really kind of defined them as either granulocytes or non-granulocytes. The granulocytes have little granules in them that will stain, and the stain is either neutral, it's basic, or it's acidic. The neutral stain ones they defined as neutrophils, and so the majority of granulocytes are neutrophils. The basic stained ones are basophils, and the acidic ones are eosinophils. Eos is Greek for red, and so usually when one is doing acid testing, red is associated with acid. The neutrophils are the granulocytes that are most commonly associated with fighting off bacterial infection. They go up in bacterial infection, they go down in nutritional deficits. The neutrophils start out as a single segmented cell, and so that segmented cell has just one band around it, and so they call that a band. And then the number of segments increases, and so as the number of segments increase, they call those polysegmented morphonuclear leukocytes, or polys. And so the polys are more mature depending on how many segments they've got in them. This is where the term shift to the left comes from. Now, for a lot of people, shift to the left just means an increased number of neutrophils. But technically, a shift to the left is an increased number of immature neutrophils. And so if you have a lot of bands, that's a shift to the left. That's usually a sign that there is a bacterial infection, and the bone marrow is starting to kick out all of these immature white cells to try to fight off that infection. So lymphs are associated with other kinds of infections. To be honest with you, when I think of what the lymphs do, I always think of a common issue that you lose your lymphs, and that's HIV. And so in someone with HIV, especially if it's reached the point of being classified as AIDS, you have certain opportunistic infections. Interestingly, you almost never have bacterial opportunistic infections. Those are very unusual. You do have a lot of viral illnesses. Cytomegalovirus can cause eye things or brain things. You have a lot of fungal infections. They can get a cryptococcal meningitis. They can get, something that is, a fungal infection like a yeast infection. And they also can get protozoal infections, such as amoeba. Actually, I think cryptococcal is protozoal. But either way, these are infections that are not usually bacterial. The lymphs are predominantly involved in fighting off non-bacterial infections. The monos are, I think, a lot harder to interpret. Most people with the monocytosis have some kind of a resolving infection. So you have somebody that's had some kind of a bacterial infection. The monocytes are kind of coming in to kind of clean things up. The issue is that if you have someone that has a substantial monocytosis, then I always have to look it up and really figure out what's on the differential and think about the kinds of things. There's certain cancers, there's other things, and see whether it really fits. I always try to look and see whether or not I have a relative monocytosis or an absolute monocytosis. And the easiest way to do this, of course, is to look at what the absolute monocyte count is. So the easiest way to do that is to take the percentage of the that's described in the differential, and then multiply it times the total number of white cells, and then compare it to a normal range. Most labs actually do this now. They give you the percentage of cells, but they also give you the absolute counts as well. And that's really been a nice advance. That's really a nice feature. Not all labs do this, and so as I say, if I have a mild relative monocytosis, but a normal absolute monocyte count, I tend not to get too worried about it. On the other hand, again, you need to be thinking about the kinds of things that are associated with the monocytosis. Just a little bit of an aside, mono or mononucleosis was called that because when it was first discovered, the cells that were involved were identified as monocytes. We now know that they're atypical lymphocytes, and so we know that the issue is not with the monocytes. Unfortunately, the name mononucleosis has stuck and will not go away, but when you're looking for someone with mononucleosis, you will have a high lymphocyte count, and they usually will identify those lymphocytes as atypical lymphs. So when you're looking at that differential. So eosinophils are most commonly associated with allergies, and so one of the things, the mnemonics that you can use to remember is worms and wheezes and weird diseases. Allergies will raise your EO count. You'll definitely see, especially in the time of year when somebody has their most common allergies, their EOs will go up. When I have someone that has EOs and allergy symptoms, I'll start them on antihistamines. Usually you'll start to see the EOs decline. There are certain intestinal infections that are associated with high eosinophil counts, and so if you have a history of exposure or abnormal stools or other issues, that's on your differential. And there are also some other diseases that are unusual. And again, whenever you have somebody that doesn't fit the classic pattern, you're going to have to kind of look it up and then parse through the various issues. Basos, unfortunately, are often an ominous finding. So the usual basophil count is 0 to 1. If you've got 3 or 4% basophils, you need to be very concerned that this patient has some kind of a cancer. On the other hand, the first thing to do with an abnormal lab test, of course, is to just repeat it. I've had a fair number of patients that have had what look to be elevated basophil counts, and then on repeat it just goes away. But if it does persist, this can be an ominous sign and is probably a good reason to get somebody to a hematologist to help them evaluate whether or not there's anything that we need to do. Platelets are also part of the blood count, and most often they're going to be in the normal range. Sometimes they're low. The normal range is usually 150 to 450 or so, 150,000 to 450,000. If they're low, you're not usually going to have to worry about bleeding until it gets down in the 40,000 or lower range. So if you have somebody that lives in the 120s or 130s, you're probably just going to monitor them, keep an eye on it, see if it's a downward trend, and just leave it alone. If you have somebody that's down in the lower ranges, you're worried about bleeding, and you've definitely got to kick in a differential diagnosis process. What we used to call idiopathic thrombocytopenia purpura is now called immune thrombocytopenia purpura, and so you're going to look for some sort of immune process. Oftentimes you don't find any particular process. Those people will usually respond to steroids. Their platelets will come up. You can control any bleeding that way. TTP, or thrombocytic thrombocytopenia purpura, can be associated with a number of different cancers. And so anytime you've got somebody that has a low platelet count, especially a particularly low platelet count, you definitely want to go looking for various types of cancers and other things that might be causing this. High platelets, I often refer to the platelet count as kind of the poor man's SED rate, because if you do a blood count and the platelet count is high 400s, low 500s, and the patient has some kind of bacterial or other infection, it does seem to be consistent with just an inflammatory process. If it's particularly high, we do need to think about cancers. If it's really high, obviously the first thing you want to know is whether or not they've had their spleen removed from trauma previously, because people that have had a splenectomy will usually run an 800 or 900,000 platelet count, which is usually kind of a benign finding in them, just because it's just associated with the old platelets not being taken out of the system by the spleen. But again, if you've got a really high platelet count, I've seen people with 1 million. Unfortunately, sometimes I see those people end up being diagnosed with a cancer. Other times they've had a spleen out. Other times we never figure it out and it seems to kind of go back to normal on its own. So at any rate, though, that is a finding that you do want to follow up on. This, I think, gives you a good basic introduction to the blood count. As noted, there's several other talks that are included on the YouTube. And so we'll stop there.